smart. Walk smart. Winners play smart.
Roughly 1 in 3 concussions are sport-related and result in a substantial number of visits to hospital emergency departments. In our current Currie Cup tournament, concussions contribute to about 12% of all injuries reported, with an incident rate of around 8 concussions per 1,000 player hours. This is similar to equivalent Northern Hemisphere data of around 8.9 per 1,000 hours. Across all our Youth Week tournaments, concussions equate to about 1 concussion every 5 matches, with under 16 players reporting the highest incident at 9 concussions per 1,000 player match exposure hours, or 1 concussion every 4 matches. At adult level, roughly 1 concussion in 6 matches would be expected. Most brain injuries in team sports, however, are in 15 to 19-year-old players and occur by striking another player through either being tackled or by tackling, and then head-to-head collisions and head-to-knee collisions. The good news is that 80 to 90% of concussed players will recover, and using a formalized graduated return to play process can safely return to rugby. The bad news is that the remaining 10 to 20% of difficult patients would require further investigation and probably multiple interventions. A relatively recent study showed that most high-level players returned to play within about 22 days, and that there was only a 6% concussion recurrence within the 3-month period that followed. Those players who had recurring concussions all had a history of previous concussion, and the one player had returned too early and against medical advice. The risk of repeat concussions is greatest within the 7 to 10 days after the initial event. Another scientific study showed that 95% of players had full clinical recoveries and had returned back to full training or match play by 21 days after a concussion. The authors did, however, show that these players had a 60% greater risk of incurring a time loss injury after having sustained a concussion, even when they went through a graduated return to play process.
One of the greatest predictors of a concussion seems to be having had one before. Most studies show that the majority of concussed athletes show symptom resolution around 7 days after sustaining a concussion. But this may not be suggestive of complete recovery, as other measures of brain function deficits may still remain. One of the hot topic scientific debates at the moment is around current concussion management and the graduated return to play sporting protocols. Scientists have raised some very important questions recently as to what might influence this increased risk of repeat concussion or risk of developing a subsequent musculoskeletal injury after having an initial concussion. 1, whether or not it is the way recovery after concussion is currently assessed and managed. 2, whether it is a physiological consequence of the primary concussion event, for example, slow reaction times and reduced balance. Or 3, whether return to play time period is in fact too short. It has been argued that the current return to play protocol focuses more on rest and less on the redevelopment and retraining of movement control and function, as would be done for musculoskeletal injuries, and that this process might in fact require more time where the brain is involved.
It might therefore, in the nearby future, end up that the return to play criteria will become more demanding on the player in order to safely return to rugby following a concussion. Ironically, another counter-argument that has been pushed in the scientific literature is that perhaps the protocols are not completely at fault. Instead, the incorrect implementation of these protocols by those involved may be the problem. For this reason, all involved in this process need to understand that it is unacceptable to return to play until all criteria have been properly met, and a more conservative approach to concussion management, and especially in the youth, may still be the wisest choice. When in doubt, sit the player out.
Younger players are more vulnerable to concussion, potentially with catastrophic outcomes. 22% of our catastrophic injuries at school level are traumatic brain injuries, as opposed to only 7% at adult level. Several factors have been proposed to increase younger players' susceptibility to concussions, such as decreased skull thickness, weaker neck muscles, greater head-to-body ratio, and decreased thickness of the insulating sheath that protects the nerve fibers in the brain. Of great concern, though, is the fact that underreporting of concussion injuries still remains a huge problem, not just in South Africa. And many of these younger players, and even their families, fail to appreciate the seriousness of concussions. A pilot study was performed recently where concussed players were routinely followed up after the SA Rugby Youth Weeks, and once they had been at home for a while. Even though the majority of players were told to do so either by the tournament medical doctor or their school coach, about 53% of them did not seek appropriate medical clearance before returning to rugby.
This is indeed a very concerning statistic. These players are putting themselves in unnecessary harm's way where they risk having a more severe concussion, having prolonged symptoms, and where the outcome could be potentially fatal. They are also letting their teammates down as they will be unable to perform at their best and will also not be able to contribute as well as they normally would for their team. No one wins here.
We are dealing with the brain, so we need to change the current player culture in collision sports. We all need to take more responsibility and be more honest about these kinds of injuries. Education and raising awareness are currently the most effective ways of addressing this problem.
The tackle phase contributes to around 61% of all concussions. There is 4 times more risk to the tackler than the ball carrier. Tackling, at roughly 3 concussions per 1,000 playing match exposure hours, or 1 in every 17 matches, has been shown to contribute to 49% of all concussions at SA Rugby's Youth Week tournaments. At our Currie Cup tournament, the tackle event represents about 70% of our concussion injuries. Head and neck position in contact has been shown to be a main contributor to concussions in both the ball carriers and the tacklers. Placing the head and neck on the wrong side during contact significantly increases your risk of concussion.
Tackle technique proficiency has also been proposed as one of the main culprits in the younger and relatively bigger, faster and stronger under 16 players at our SA Rugby Youth Weeks. In our mechanistic studies on concussion in our under 18 Youth Week rugby players, 60% of concussive tackles were unsuccessful, with only 1 tackle being completed. Whereas, during the non-injury tackle events, 58% were successful tackles and 53% of the tackles were completed. Besides good head and neck placement when making the hit, getting the shoulder onto the ball carrier and driving through the tackle with the legs after making contact were also moderately protective against concussions. This once again supports the box smart approach of continually teaching, coaching, and training only safe and effective tackle techniques. These techniques must be trained and coached sufficiently before players take to the field in match situations.